So good morning, everyone. This is just after 8, and we have a pretty good quorum. So let's get going. Today, we are delighted to host Dr. Kate Wiles from the UK. Dr. Wiles is a consultant nephrologist as well as an obstetric physician at Barts Health Trust in the UK in London. She is a lead investigator on a multi-center prospective cohort study examining the implications of CKD for pregnancy and long-term female health. She's extensively published in this area, including the only national guideline on in this issue on the management of pregnancy in people living with kidney disease. And I'm sure many of you may have read textbooks, especially the trainees on the Oxford textbook, as well as the comprehensive clinical nephrology, where she has authored the relevant chapters on this issue. So welcome, Dr. Wiles.
Thank you so much. It's a real pleasure to be talking across the world. I'm going to talk about pregnancy and kidney disease. So the easiest way to solve this problem for most nephrologists is just to tell women not to get pregnant. And that is what we used to do. So this is the Lancet in 1975, and this is our eminent historical colleagues writing about pregnancy and kidney disease. And they talked about children of women with renal disease used to be born dangerously or not at all. And they were very disappointed because many women disobeyed their doctor's orders. So that's 1975, and I hope it looks a bit different now. So this is the UK Kidney Association today, and this was the first guideline across the world, I think, about pregnancy and kidney disease. Some more have kind of been written since. They all look very similar. It's free online, you can use it. The reason that it's worth me coming to talk to you is because this is really important. So when we ask people with kidney disease what they think, 74% of them will say pregnancy is very important. And actually, if they can't conceive, that impacts their self-worth. The burden of pregnancy is great. It affects family, it affects work. They worry about transplant loss. They worry about their kidney disease. There's a real disproportionate fear of birth defects with immune suppression, which I will come to. But actually, for most women, the risks of pregnancy are acceptable, and it is quite traumatic when physicians tell them or warn them against pregnancy. What was interesting when we looked at qualitative data for me is actually what the patients think is risky is not actually what I think is risky. So we need to get a bit better about being on the same page as our patients. So this is what I'm going to offer you today. So I'm going to give you some quick rules that it's worth nephrologists knowing about pregnancy. And then basically I'm going to talk you through a case. And it's a pretty straightforward case. It's my bread and butter. It's what I see every week. But we will deal with all of these aspects of kind of management of kidney disease in pregnancy. Rule number one is that actually CKD is quite a useful term. I do tell my obstetric colleagues that actually CKD is not a diagnosis, and I try, if they're going to pick up the phone to nephrologists, to at least find out what the diagnosis is. But actually for pregnancy, the specific CKD diagnosis is often less important. The things that impact pregnancy are three things: the level of kidney function, whether you are hypertensive with it, and whether you leak protein. The only addition to that is if you have a systemic disease that has other implications. So for instance, lupus, you might have antibodies that impact health, and systemic disease activity is a real risk for adverse pregnancy outcome. Diabetes, we will come to, that obviously adds more risk. So that's rule number one. Rule number two is that EGFR doesn't work. The formulae, in fact, all the formulae were never designed to work in pregnancy, and when we've looked at them in pregnancy, they don't work in pregnancy. And the other problem with trying to make a formula that does work in pregnancy is that creatinine is not in a steady state. So these are actually Canadian data, and this basically just shows creatinine before pregnancy, and then in pregnancy, you can see it's falling throughout the first trimester. There is a plateau, a nice low plateau in the second trimester, and then in the third trimester, it climbs physiologically. And then there's a little bit of a peak after delivery. Presumably this is some AKI measured in routine blood tests. So you can't really have a formula that works because EGFR is very rarely in a steady state, especially in the third trimester, which is when you're most worried about kidney function often. So when we stage kidney disease in pregnancy, we have to use a pre-pregnancy EGFR, and in pregnancy, the chat is all old-fashioned serum creatinine. The next rule is that proteinuria is different. So when you fall pregnant, as a rough rule, your proteinuria will increase. So when I talk to people for pre-pregnancy counselling, I look at the level of proteinuria they have, and I predict what it's going to be in pregnancy. And actually, if it doubles in pregnancy, that doesn't worry me. That doesn't make me think that there's a disease exacerbation without other evidence of it. It's only kind of a more than doubling that we sometimes look for clinical significance about. If they're on RAS inhibition, so if they're on an ACE or an ARB going into pregnancy, you obviously have to stop that in pregnancy. So in fact, stopping the RAS inhibition will double your protein, and then pregnancy will double it again. So for women with proteinuric diseases, actually sometimes you're looking at a quadrupling for physiological pregnancy, and you just need to work out how significant that will be. And if it's going to tip them into the nephrotic range where they're going to become symptomatic, that's a worry. We don't know very much about the SGLT2s, but we think they're a bit like RAS. And actually you have to stop them for pregnancy, and the proteinuria will go up, and then it will increase again for pregnancy. Just to say that if you're flipping between an ACR and a PCR in pregnancy, the ratio is slightly different in physiological pregnancy. The obstetricians are actually more familiar with cutoffs for proteinuria in pregnancy because they look at them a lot for preeclampsia diagnosis. But actually a UPCR of 30 is the upper limit of normal for pregnancy. A UCR of 8 is the upper limit of normal for an ACR. So the kind of the balance between the two, the ratio between the two, is not what you might expect. And my last rule, and this is the one that haunts me every week, is that diabetes just adds loads of risk. So if you have diabetic nephropathy, these actually have become my highest risk pregnancies. I used to worry about lupus, but actually I worry a lot more about diabetes now. And this is a nice meta-analysis that basically looks at adverse maternal outcomes and adverse baby outcomes. And you can see if you have nephropathy with your diabetes, all of these outcomes are more prevalent than if you have diabetes without nephropathy. The only one that you don't get if you've got nephropathy is your babies don't grow very big. So actually the placental function is really impaired in diabetes. Even if you have lots of sugar floating around, the babies don't get macrosomic. Placentas are bad, and it contributes to all these adverse outcomes. And then in my study, which I'll show you some data from later, where we took all our pregnancies with CKD, in fact, when I looked back, there wasn't a single normal pregnancy outcome in the people with diabetic nephropathy. But I'm not going to give you a diabetic case. I'm going to give you a transplant case. So this is the case, and I'll talk you through it and show you some data along the way. So this is a 37-year-old with no previous pregnancies. No previous pregnancies is tricky because she's not told me what her risk is. I like previous pregnancies, and I like all of the details because that kind of tells me where this one might be headed. Her background diagnosis is reflux nephropathy, and she ended up with end-stage renal disease at the age of 29. She was on peritoneal dialysis for 3 years before getting her living-related transplant. Her mother had to come from abroad, and there was a delay with visas and things. Hence, she was on dialysis for 3 years before her transplant. But she's actually done very well since she had her transplant. She's never had any episodes of rejection or significant infection. And her blood pressure is reasonably well controlled on the treatment that's listed here. So this is her kind of kidney function going into pregnancy. So her creatinine is pretty static with an EGFR of about 40 and a PCR also of about 40. So because this is a utopian lecture, she obviously comes for pre-pregnancy counselling. And the aims are that I try and provide individualised risk. I actually write quite detailed letters in language for the patient, not for clinicians. And I talk about risk to both mother and baby. My job is to remove anything teratogenic or fetotoxic. So for her, that is both her MMF and her ACE inhibitor. And then I just think about other things, other aspects of health for pregnancy, because it's an opportunity to do this, included COVID vaccine, which remains a hard sell. Just regarding transplant patients, actually what I do for all of the transplant patients is I give them a treatment plan. So if they develop hyperemesis at the beginning of pregnancy, they don't have to find help. I give them a prescription they can just collect with nice effective antiemetics to make sure they can continue taking their immune suppression in that eventuality. So what is her risk? So just to say, I'm going to talk about risk, I'm going to talk about MMF, and I'm going to talk about ACE inhibition. So what is her risk? So historical cohorts were often small. It was before we used EGFR. There was loads of variation in diagnosis. People thought CKD were different things, and people thought preeclampsia were different things. They didn't correct for age, the risk of diabetes, social factors, when you got your antenatal care. They lumped all kidney disease together. They used composite outcomes, but something bad was going to happen, but perhaps we couldn't say what, and they loved binary outcomes. So, you know, they're very interested in whether you get pre-eclampsia or not. Actually, I'm not interested in that. Pre-eclampsia at 26 weeks is a very different disease from pre-eclampsia at 38 weeks, and I like some kind of granularity to my data. Can we do a bit better? So this is Italian cohort data. This is by Gio Piccoli, and she published her CKD patients against controls. And she looked at a whole host of outcomes. And what you can see is the following. So the first thing to say is that even if you have CKD1, even if your creatinine is normal, actually adverse outcomes in pregnancy happen between 2 and 7 times those of control cohorts. So CKD per se carries some risk. The next thing to say is by the time you get to CKD 4 to 5, your risk is much, much increased. So somewhere between 5 and 44 times. And our patients sat here. So what we could tell her on the back of these data is you're 2 to 13 times more likely to have some adverse outcome. But if you look, CKD is obviously more common than the other advanced kidney disease in women of reproductive age. This is based on 37 women. And yet 47 across CKD 3, 4, and 5. These are the ones we worry about. So myself and my colleague Phil Webster, who works at Imperial, basically took our CKD 3, 4, and 5 cohort and looked at what's happened to see if we could describe it based on more women. So these are the data from the paper, and I've just turned some red and kind of rounded them up just to make life easier. So now if you have pre-pregnancy CKD 3A or 3B or 4 to 5, I can tell you when you're going to deliver. You're going to deliver at 37, 36, or 35 weeks. Are you going to deliver very early? So actually, I'm not worried if it's a little bit early, but actually before 34 weeks has more implications for kind of neonatal and childhood health. So is that going to happen? 1 in 5, 1 in 4, nearly half. Is your baby going to be small, which also impacts health? 1 in 10, 1 in 5, nearly half. Are you going to lose your kidney function? Probably, definitely. I'll come back to that. So in terms of kind of the pregnancy outcomes, the biggest predictor of whether you're going to deliver early is hypertension. So if you are hypertensive going into pregnancy, the chance that you're going to deliver early increases 17 times. Are you going to have a low birth weight baby, which impacts on health? Actually, the biggest predictor of that was proteinuria. But you guys, I think, are all nephrologists, so you don't really worry about the babies too much. You worry about the kidneys. So let me show you the kidneys. So this is what happens to the kidneys. So this is EGFR, and it's basically plotted over time, and it's plotted according to pre-pregnancy CKD stage 3A, 3B, and 4 to 5. And so we just basically took all the EGFRs and we plotted them before pregnancy, no EGFRs in pregnancy, and then we plotted them afterwards for each of the stages. And I'll just highlight what it shows. So the first thing to say is that at each of these CKD stages, you lose kidney function in relation to pregnancy. So where you end pregnancy is not where you went into it. There is a jump for each of those pre-pregnancy CKD stages. But perhaps reassuringly, actually, when you measure these lines, it doesn't accelerate your kidney disease afterwards. So how you were declining before pregnancy is how you continue to decline after pregnancy. So you get a jump, but then your kidneys go back to exactly what they were doing before, which is neat because you can measure it. So you can look at what your EGFR was doing before pregnancy, you can look at the jump in pregnancy, and you can turn it into years. So I use these data all the time. So if someone's coming to me and wanting pregnancy advice in their pre-pregnancy CKD stage 3A, I know that pregnancy for their kidney is not 9 months long, it is 1.7 years. And if they're 3B, it's 2.1 years. And if they're CKD 4 to 5, their kidneys are basically going to do 5 years worth of work. And if you think 5 years worth of work is going to tip them into dialysis, you need to get ready to do it in pregnancy. What contributes to risk in terms of losing your kidney function? Well, it's what I've already told you, and it's what the other data showed. Hypertension adds risk, proteinuria adds risk, but actually having a transplant per se does not, reassuringly. So transplant does not make a difference yet. So that's her risk. I also need to get rid of her MMF. MMF is teratogenic. It causes abnormalities in about 15% of patients. You need to get rid of it 6 weeks before pregnancy for it to wash out, but in reality, you need 3 months. And I always say to the patient, please give me 3 months, because I don't want it to just wash out. I want to know that your transplant or your lupus is stable on whatever I've switched it to, which is usually azathioprine. Is this safe? So this is where I really want some published data, because I don't really have any to say it's safe. I do it all the time. And actually, we've only got abstract data showing that actually it looks okay, but nothing peer reviewed, nothing cohort data. And what I'm really interested in trying to find is the women we switch who do not get pregnant. And I want to prove that actually it doesn't change what their graft or lupus disease activity does. Hopefully it will come. And her ACE inhibitor, what are we going to do with that? So we've all known for a long time that ACE inhibitors are fetotoxic, which is different from teratogenic. So teratogenic causes a problem with the way the organs develop in the baby. Fetotoxic damages an already formed organ. And they are fetotoxic. So in the second trimester, once the fetal kidneys have formed, ACE inhibitors affect how those kidneys will then work. But what I'm wanting to know, if I'm going to stop a medicine before pregnancy, is about the first trimester. And actually, if you want to see what a drug does in the first trimester, you have to compare not just the drug with a control cohort, you have to compare women taking the drug with women with the disease who are not taking that drug. That's the fair comparison, because the disease quite often has an effect. And when these studies did that data analysis for us, actually, they showed that the malformation risk in the babies was the same if you had hypertension. It didn't actually matter whether you took an ACE inhibitor or another drug. And there isn't any increased risk compared to unexposed hypertension. And that kind of makes sense, because quite a lot of the women who are on RAS inhibition, at least at the time these studies were done, were the diabetics, and diabetes is associated with abnormality. So you weren't actually measuring an effect of the drug, you were measuring an effect of the disease you were treating. So what did we say in the guidelines? So we said, basically, if you're taking an angiotensin converting enzyme inhibitor, then you can take it up until conception, but just tell women what to do with their positive pregnancy test and tell them when they should stop it. And then after we produced the guideline, this paper came out. And I thought, oh my goodness, I'm going to have to rewrite the guideline, because this made both angiotensin converting enzyme inhibitors and angiotensin receptor blockers look bad. And I'm just going to show you the data, because if you look up ACE and ARBs in pregnancy, this meta-analysis appears. So what they did quite nicely was they compared ACEs and ARBs to no antihypertensives. Now, I've already told you that's not a fair comparison because it takes the disease effect away. So unsurprisingly, if you're on an ACE and ARB compared to a control population, adverse outcomes increased or abnormalities increased. And then they compared other antihypertensives to that same control population. And they said, but look, if you compare other antihypertensives to a control population, they don't increase risk. So quid pro quo, that ACE inhibitors must be different from other antihypertensives. And that is their summary. Actually, if you look at the paper where they actually compared ACEs and ARBs to the other antihypertensives, which is the fair comparison, you see the following. So first of all, you see that the majority of the data crosses the line of no effect. And actually, it's this paper that makes the ACE and ARBs look harmful. But actually, in this case, no one was hypertensive. This was beta blockers for migraines and heart disease, which is different. So they took the disease away. And so I don't think this meta-analysis is fair. And the biggest study we have was omitted based on study criteria. So what does all this mean to me? This means this paper does not change what I recommend. And I say, if there's a good reason, I continue ACEs. And actually, there's less data for ARBs, but I kind of think they're the same. And I used to switch them over semantically, and now I don't worry too much about it. I continue them both until conception. And I say, do a pregnancy test every 4 weeks. And if it's positive, stop it. And kidney disease is a very good reason to be on an ACE or an ARB. And, you know, there's a risk of uncontrolled hypertension. So if you're going to treat them with something. So she converts from her MMF to azathioprine, and 1 year later, her graft is stable. Creatinine's still 140 with an EGFR 144 with an EGFR 40. Her blood pressure is controlled on ramipril because I haven't stopped it, and I'm very glad because it's a year later. But she hasn't conceived, and she wants to know about her fertility. So what does her fertility look like? So you might remember vaguely when you did obs and gynae in medical school that this is what a normal menstrual cycle looks like, with various hormone levels peaking and troughing across the course of the menstrual cycle. This is what it looks like in dialysis. So what I can't tell you is at what stage of CKD this starts to look like this. But I can tell you that advanced CKD impacts fertility, and it does it because there's low levels of estrogen and there's a bit more prolactin floating around, and these inhibit your hypothalamus pituitary, which doesn't surge, so you don't ovulate, and sometimes we put toxic stuff in like cyclophosphamide. So can I help her? Can I assess her fertility? So there's a bit of a trend to measuring AMH, which is anti-Müllerian hormone. So this is a hormone that's secreted by the preantral follicles, all the follicles that are kind of sat in your ovary. They all secrete AMH, and then at some point a follicle becomes dominant, and that's what ovulates. But when you measure AMH, you're measuring kind of what's left in the ovary. So it gives you an idea of ovarian reserve. And when we looked at this in CKD, we basically found that it was decreased across all ages. So black is control and red is CKD, and these are the different age groups. And so what you can see is that your AMH, your ovarian reserve, if you have CKD and you're 25, is very similar to your ovarian reserve without CKD aged 40. So CKD does impact ovarian reserve, but does it impact fertility? And actually, the problem with this is that this is not a good predictor of conception. So people do measure it, but I don't measure it because I don't know what to tell the patient it means. Actually, if you are younger with a regular period, actually that's the best predictor of whether you're going to fall pregnant or not. If you are older or your periods are irregular, I have a really low threshold for seeking fertility treatment. Your fertility colleagues will use it to predict response in IVF. So if they see a low AMH, they'll give higher doses to stimulate the ovary, and I caution them against it because actually I think these patients are younger, therefore age is protective and they're more likely to respond. And these are the patients I do not want them to overstimulate because of the risk of AKI. So I do use AMH just to say, don't interpret it in CKD like you do outside, because I think there are risks. And I think actually a lower dose of ovarian stimulation is probably okay in younger patients. But she doesn't need fertility treatment. Again, utopian world. She actually comes pregnant 10 weeks. And at 10 weeks, her creatinine's fallen to 126 and her PCR has increased to 84. This makes me very happy. This is normal physiology. Her creatinine is falling and her proteinuria has gone up. So this is a kidney that looks like it's coping with pregnancy. Her blood pressure is now controlled on labetalol because she's off her ACE inhibitor at her positive pregnancy test. She has a TAC level of 5.1, a hemoglobin of 99. She grows E. coli in her urine because that's a routine check. And she's started on aspirin. So let me just show you some data about TAC and hemoglobin and UTIs and aspirin. So TAC levels fall in pregnancy because of change in metabolism, but I have a little caution about TAC levels. When we measure TAC levels, we measure whole blood levels. Actually, I'd really like to be able to measure free TAC. It turns out it's really hard. And it's okay when you're not pregnant because actually most TAC is bound. But in pregnancy, there is an unbound proportion that we cannot and do not measure. So these are the data. Look how small the ends are. This is what you get in pregnancy, guys. But what you can see here is this is pregnancy. So there's a component of unbound TAC, and this is postpartum, so not pregnant. So there's this bit of TAC here we're not measuring in our standard levels. So what I'm very happy to do is end for the lower end of the non-pregnant reference range. I think if we're getting to the high end of a non-pregnant reference range, I see TAC toxicity. Just as a reminder that obviously TAC is diabetogenic, and so we need diabetes screening, and I move it forward in pregnancy for my patients who are taking TAC. EPO. So this is a really terrible graph, but it's the only one that's published. But basically, over pregnancy, EPO concentrations are required to double as part of normal physiology. So you might have kidneys that can make enough EPO when you're not pregnant, but they can't double it in pregnancy. So if a patient's on EPO, just get ready to double it in pregnancy. If they're not on it, but their creatinine's about 100 going into pregnancy, get prepared to start it. Safe in pregnancy, safe in breastfeeding. Urinary tract infection, there are no good data about UTIs in pregnancy, either specific to CKD or I think outside of CKD. No one really knows what they're doing. This is based on antibiotic prescribing between 1964 and 1985, which I don't think applies to modern practice. There's definitely no good data about our patients who are taking immune suppression, but we know UTI is a problem after renal transplants. So this is purely consensus of people sitting in a room deciding what they wanted to say. And we basically said that if you've got an abnormal urinary tract or you're immune suppressed and you've got infection, you treat it like you would, but then we consider prophylaxis to prevent further infection. Aspirin. We use aspirin in pregnancy a lot. We use it to prevent preterm preeclampsia. These are all the meta-analysis data for aspirin. Lots of people used it at different times in pregnancy and different doses. But when you try and pull that out, what you see is aspirin works best if you start it before 16 weeks and you use a dose of more than 100 milligrams. So in the UK, that has to be 150. I think you might have 122 or something different, but we have to use 150. So that on the basis of this, the best trial data used 150 versus placebo. And actually, you don't need to treat that many women to prevent problems. So the numbers needed to treat are 16 to 19 to prevent low birth weight babies and preterm preeclampsia. And it makes a huge difference to the babies. So what you can do is, if you can stop your preeclampsia being preterm and you make it term, actually the babies are in NICU for nearly 3 weeks less. Good for the babies, good for the NHS, because that costs us a lot of money. So does this work in CKD? That I can't tell you. So we have no CKD data about whether aspirin works and prevents preterm preeclampsia. I have some data just about chronic hypertension, which may or may not be relevant. So this is the same trial. These are all the women where aspirin works, especially if you take it. It's nice to see. And this is if you have chronic hypertension. So this is all comers, not so convincing it works, even if you take it. Why is this a problem? Well, I'm not sure what this means, because this trial wasn't designed to look at hypertension. This is an ad hoc analysis later. And also, I don't know how you diagnose preeclampsia when you've already got high blood pressure. That's just a very difficult diagnosis to make. And you could just wait until you get all the other parts of preeclampsia, or you could just deliver the pregnancy, and then you might not see the preeclampsia in this cohort. So actually, aspirin doesn't cause harm. We don't have better data. It works in high-risk populations. Our women are high risk. I give it. So she continues throughout her pregnancy, and these are her weeks. So she's 24 weeks, then she's 28 weeks, then she's 32 weeks, and then she's 34 weeks. She has normal diabetes screening, she has normal growth scans. And at 34 weeks, however, things look a bit different. So her blood pressure looks different, 151/95. Her creatinine looks different, makes me anxious. Her urea looks different, and her PCR looks different. Again, even compared to these kind of levels beforehand. So if you are an obstetrician, you say at this point, oh my goodness, does she have preeclampsia? And if you are a nephrologist at this point, you say, oh my goodness, does she need dialysis? So I'll just talk a little bit about preeclampsia and a little bit about dialysis. So does she have preeclampsia? Very good question. This is the great and the good. This is the International Society for the Study of Hypertension in Pregnancy, and they tell us how to diagnose preeclampsia, and they rewrite this every kind of 5 or so years. And this is how you diagnose preeclampsia. So you need new blood pressure, new high blood pressure after 20 weeks. Well, she started pregnancy on ramipril and then labetalol, so she cannot have that diagnostic criteria. And then you need evidence of endothelial dysfunction. So that could be proteinuria with a new PCR of 30. Well, she went into pregnancy, her early pregnancy one was about 80, so she can't have that. Or you have endothelial dysfunction in your organs, a new creatinine of 90. Well, she started at 126. So we could just wait for her liver to get sick, or we could wait for her brain to get sick, or we could wait for her platelets to fall, or we could wait for the baby to get sick. And so it's really difficult diagnosis to make if you have proteinuric kidney disease. So whenever they release this kind of diagnostic document, I kind of control F to look for CKD. Tell me what I need to know. Tell me how to do this. And this is what the document says. So it just says renal disease is complex and beyond the scope of this document. So nobody knows how to make this diagnosis. Even the great and the good who manage preeclampsia don't know how to do it when you've got kidney disease. And that makes life really tricky. So your risk of preeclampsia goes from 0 to 100%. And if you have chronic hypertension or type 1 diabetes or a history of preeclampsia, your risk sits here. But if you have CKD, your risk is here. CKD makes a huge difference to your preeclampsia risk. But we can't diagnose it. No one's told us what diagnostic criteria to use. And yet, if we don't diagnose it, mothers and babies come to harm. And if we overdiagnose it, we deliver babies who do not need to be delivered. It's really tricky. So does this help us? This is placental growth factor. So this is what we use in the UK. It's a little protein. It's secreted by the placenta, and it tells you about the health of the placenta as a rough rule. And this is what it does in normal pregnancy. So the placenta grows and PLGF goes up, and it peaks at about 32 weeks, and then it falls physiologically. If you are going to develop preeclampsia, your levels of PLGF in your plasma are lower at all time points. And by the time you've got preeclampsia, your levels of PLGF are really low. That placenta has failed. So you can use this where other diagnostic criteria are not helpful. Does it work in CKD? I don't know. No one told me about the CKD in the published data. So we just have to presume. So this is what we do in the UK. If you have a normal PLGF, you can carry on. If you have a low PLGF, your placenta's not working and it's preeclampsia. And if you're somewhere in the middle, you watch them more. And you can either just use PLGF or you can use it as a ratio with anti-angiogenic factors, works the same. So remember this cutoff, PLGF of more than 100 is normal. Okay, what happens if you have kidney disease? So these are my PhD data. And the problem is that CKD is different. So CKD is an endothelial disease. So in fact, you can get a preeclamptic phenotype before your placenta is that sick, because your endothelium is already dysfunctional. And that is exactly what you see. So these are the women with CKD who did not develop preeclampsia. That's their PLGF going up, peaking at 32 weeks and then falling down. Good, nice to see. These are the ones who developed preeclampsia. And what you can see is it is lower at all time points, but it never drops below that 100 that works in the control population. And that's probably because your placenta doesn't need to be that sick for the mother to develop a preeclamptic phenotype, because they've already got abnormal endothelium. So what you need to know is, if you're going to use this and look at it, is your PLGF cutoff is not 100 if you have CKD, it is 150. Okay, does she need dialysis? So we worry about urea going up in pregnancy because we used to inject it to cause an abortion. Babies do not like urea. At what level is urea toxic? I cannot tell you. The data are from the 1960s. So in 1963, if you had a urea of more than 21, all the babies died. In 1968, if you had a urea of more than 18, half the babies died. Tells you more about obstetric management and blood pressure management in the 1960s than it does about urea. But these are the only data we have. This is some data that basically just shows that actually if your urea, once it gets to kind of 17, you're more likely to deliver early and you're more likely to have a low birth weight baby. So it's these data, which is retrospective and may not be the best data, that swayed us with what to do. So we said, actually, if your urea is more than 15, depending on what's causing it and what gestation you're at and what trajectory you're at and whether you've got other factors, start to talk about the need for dialysis. If you're going to start dialysis in pregnancy, you do not need a lot. It's a bit like how you start dialysis at any other time. So we're really swayed by these data that show that more babies survive if you give 56 hours of dialysis compared to 20. But these are women established on dialysis. They have no residual urine output and they need a lot of dialysis. If you've got working kidneys, just not enough, you can start low and go slow. And I start 2 hours 3 times a week and work up. And I try and keep the urea less than 12. So what happens to the patient? In fact, diagnostically, it's not difficult because actually we can't control her blood pressure despite 3 agents. She's got progressive kidney injury. Her placenta doesn't look normal in terms of blood flow. She has preeclampsia, and so we deliver her. She doesn't need dialysis because it's not a treatment for preeclampsia. So now I'm just going to quickly mention mode of delivery, breastfeeding, and long-term transplant function. So can she have a vaginal delivery? Yes, that is it. That's all you need to know. If you want to a little bit more detail, all women need to have the option of having an emergency cesarean because you just never know what the baby or the mother are going to need at the time. So I have to imagine that even if we're planning for a vaginal delivery, there is a plan for a section. And so I think about that in the early 3rd trimester for all the women. And I will make a plan, a documented particular plan for complex anatomy. So that's dual transplants or people who we know have complicated transplant anatomy, or if they've got previous CACUT, their pelvis just may look different and the surgeon may not be cutting what they think they are cutting. You can always ask your obstetric colleagues to do a real-time scan. They scan babies. They scan babies' atrial septal defects. They can find a maternal transplant, I promise you that, and they can avoid it. If you're not sure about the anatomy and you need to do things quickly, the safest way to do it is to cut the skin vertically. That avoids the graft. You don't cut the uterus vertically, that's bad for future pregnancies. You cut the skin so you can see where the transplant is, so you can make your horizontal incision in the uterus. Can she breastfeed? Yes, she can. We've got good data on azathioprine. We've got good data on Analypil, which is my ACE of choice to restart. And these are the data on TAC. So the baby's born with the same TAC level as the mother, but it doesn't matter whether the baby bottle feeds in black or breastfeeds in white. They clear that TAC the same rate. Breastfeeding does not cause them to accumulate tacrolimus. What's going to happen in the long term? These are slightly old data going back to 1966. These are from Australia and New Zealand, but they basically matched women who had a pregnancy, transplant patients with a pregnancy, to transplant patients without a pregnancy, matched by kind of level of function and graft. And it basically doesn't matter whether you have a pregnancy or not, the grafts survive at the same rate. And even over 20 years, there's no measurable effect from pregnancy. Just as a caution, this is not really a problem with pregnancy, this is a problem with CKD, that some transplants and patients do not survive. And in this cohort, the median age of the child when the mother died was only 12. Now, I don't think that's true. I don't think that reflects function now. Again, this is going back to 1966. I think our data would look better across kind of all high-income countries. But just to say, this is a factor with CKD, and trying to put this into pre-pregnancy counselling is really, really hard. Many thanks. A whistle-stop tour of pregnancy. I'm very happy to take questions.
Fantastic. That was quite an overview. That was a fabulous talk. Thank you again, Kate, for that wonderful overview. So we do have transplant colleagues as well as some of our colleagues who do more of this than others in the audience. So please, unmute yourself and ask. Oh, the conference room has questions. Please go ahead.
Okay. Hi there, Dr. Wiles. Great talk. I had a question and get your thoughts on preeclampsia. You mentioned in there that talking about endothelial disease, and I know there's an old study I remember seeing looking at biopsies in pregnant women who had hypertension, and the majority of cases had endotheliosis, a form of glomerular limited TMA. And so is there any interest in doing complement pathway testing for maybe not like as a screening, but, testing in patients that have CKD and preeclampsia? And do you know if there's any interest in eventually studying complement pathway blockers for preeclampsia? Do you see it as a form of a glomerular TMA? And where would you see that heading?
It's a really, really good question. I think there is quite a lot of work about complement inhibition in a normal placenta and complement activity in an abnormal placenta. The difficulty is measuring it, so I've tried. So when we looked across a whole load of proteins to see what might be helpful specifically in CKD, the problem is trying to measure complement, not just complement protein components, but complement activity. And actually, I think we measured kind of complement components, but I don't think that is actually what we wanted to know. I think we wanted to know activity, which is more difficult to assess. And whether things like eculizumab would modify preeclampsia, I don't know. My problem is that by the time you're inhibiting complement, your placenta just isn't working. And even if you can ameliorate the maternal disease, the problem is that you've got poor blood flow to the baby. So I'm not sure whether actually you're going to prolong the pregnancy that much. What I'm more interested in is getting a good working placenta from the beginning. So if you can, I think the bang for your buck, if you really want to treat preeclampsia, is not waiting for it to manifest and then trying to switch off the process. The real bang for your buck is getting a better placenta at the beginning. That's where aspirin works. And I think we should, and aspirin, the data for aspirin are much more convincing for anything at the time of delivery. So we have tried, for instance, we've tried statins, for inflammatory stuff at the time of delivery. And there are some American colleagues who are trying that anti-antigenic factor that I showed you with PLGF. They're trying to take it off once you've got preeclampsia. But I think trying to prolong a pregnancy by a matter of days, I'm not sure that's what changes outcome. I think you want better placentation at the beginning. So aspirin works, I think, though I can't prove it. And I think simple things like blood pressure control. So not losing blood pressure control while your placenta is forming between 6 and 16 weeks, that we forget. So yes, I think there is a role for complement. Whether switching it off changes outcomes, I don't know. It's a very good question, and we've tried to look at it. And not been very successful. But I think the investment goes in when the placenta is forming, to be honest.
Thank you.
Thank you. So Ayub has shown his video. I guess he has a question to ask. So Ayub is our Dr. Akbar is our equivalent for what you do in London.
Oh, amazing.
Yeah.
Thank you for an excellent talk. I have some practical questions. Are you using amlodipine for blood pressure control in UK?
Yes, all the time.
All the time. Great.
Yes,
Okay.
so the data's coming. That data I have. We've got a big cohort, 200 patients. I've used it for ages because I just like it. It's once a day, and there's no reason why it should be terrible when nifedipine is fine, and it's not associated with adverse outcomes over and above hypertension per se. I use it all the time.
Great. So the other question was, what's your target blood pressure in patients who have normal blood pressure and land up in the hospital with preeclampsia, severe preeclampsia?
Severe preeclampsia.
Yeah.
So once they hit more than 160/110, my initial target, where I just want it at the beginning, is to bring it down below 160/110. And I don't want to do that too quickly. So I wouldn't use anything fast acting. I don't want to precipitatively drop it, because you do see kind of threshold ischemic strokes if you bring down maternal blood pressure too fast. And I think if you see that, you're probably infarcting the placenta as well. But when the placenta infarcts, we call it abruption. But we don't blame our hypertensives. Once I've got it below kind of 160/110, I want it below 140/90 ultimately.
Yeah, the patient would probably get delivered before that happens. But 110 diastolic is what you are targeting. Some people target less than 105 initially, but you guys are targeting less than 110, right?
Yeah, so the initial, so we, first of all, we get rid of severe hypertension. So we bring it down below 160/110, and then we try and give a normal blood pressure, which would be below 140/90, we think. The problem is 160/110 became the diagnosis of severe maternal hypertension. So that's what's always associated with adverse outcomes, because that's how we defined an adverse outcome.
And there was old data about cystatin C being a marker of preeclampsia. Is there any other data saying cystatin C being a marker of preeclampsia?
Yeah, so we've tried to look and see if cystatin C would offer us a better measure of kidney function in pregnancy. The problem is the placenta makes of it.
Yeah. Oh, not kidney function as a marker of preeclampsia, not kidney function. I actually published that it's not a good marker of in pregnancy for GFR, cystatin C.
Yeah, but I think by the time you change kidney function, you see, you're going to change cystatin C. So it might be a marker of, it might be a more sensitive marker of AKI associated with preeclampsia. But just remember that in women with CKD, you tend to find preeclampsia in the kidneys. Like, it will make the kidneys worse. Their kidney is literally a sitting duck, a sitting target for endothelial dysfunction. But outside of CKD, you can have entirely normal kidney function and no proteinuria, but you can have rip-roaring CNS preeclampsia. So whether cystatin C is helpful when you don't have kidney involvement, and whether it adds anything over serum creatinine, I don't know.
Also, we might be able to measure free tacrolimus levels. We are looking into it.
Oh, if you can, then ring me. Like, literally, you can.
Yeah, we can collaborate on it.
Yeah, that would be amazing.
Thank you.
Fantastic. I think someone in the conference room has some more questions.
Yeah, about diagnosis of preeclampsia. So PLGF levels are high. Is that because it's renally cleared, and if your GFR is lower or kidney function is lower, you don't clear it?
Yeah. So PLGF is helpful. There's no magic diagnostic test once you have CKD. I think PLGF is helpful because actually it tells you what the placenta's doing. By the time you're CKD 4-5, all of the markers become less good. So there is an element when the kidneys don't work, it looks normal, not because the placenta is working, but because it's not being cleared. There is an element of that, but actually, I think it's more that the endothelium is primed. And the reason I say that is because when you look at people without CKD who have significant AKI with their preeclampsia, their PLGF is low.
And you didn't talk about SFLT. Does it have the same problems?
Sorry, say that again.
Serum FLT1.
Serum FLT1.
Yeah.
Does it have the same problems?
So it's basically an alternative to PLGF. So one's angiogenic, one's anti-angiogenic, one goes up, one goes down. You can measure one or the other, or you can measure a ratio. The only thing I would say is you just need to be careful what you're measuring. If you're going to measure them in plasma. If you measure them in serum, you get some activation in the kind of the process by which serum is preserved. So when I've tried to look in the UK, we can only measure S-FLIT in serum, and it is useless in CKD. So that's why I presented the data on plasma PLGF. We don't have capacity, but I think definitely the Americans are measuring plasma S-FLIT, and that would be a good alternative.
Peter, 4 times more expensive S-FLIT.
Yeah, I mean, I don't think it adds anything. It's just one or the other.
Yeah, we are just we just started last week, I think, or the week before, to measure PLGF. I think Ayub led that locally. So we are still not sure how we are going to use that. And we are not measuring S-FLIT locally because of cost reasons, I suspect.
Yeah, I mean, I don't measure S-FLIT. I don't think they add to each other. And in fact, for the hospitals that do run the ratio, I don't look at the S-FLIT. I want to know what the presenta's doing.
Greg.
Thank you for that talk. I mainly look after transplant patients. So again, interested in that earlier discussion you had around pre-pregnancy counseling, and obviously don't want to return to 1975 with an obey, disobey. But are there combinations of, disease, diabetes, low GFR, and severe proteinuria, where you would say, the risk to the graft, I'm not talking about other outcomes, are so high that I personally would not recommend it, or you just outline these risks to the patient?
Yeah, so I say I'm not a gatekeeper of choice. I'm a gatekeeper of information, but it's got to be good information. It's got to be individualized. But there is a threshold of risk where I cannot imagine that level of risk is worth it. But that's me, and I have to try and put myself in the patient's circumstance. So, from a doctor's point of view, there's no advantage ever to anyone being pregnant. Like, just medically, it's just, you shouldn't do it because it only carries risk. And the benefit to the patient is very personal. So you have to allow kind of that balance. But my personal threshold where I have concerns is, I think if you walked into me pregnant, if you fell pregnant and we weren't having a pre-pregnancy conversation, would I offer you a termination? Because I think your risk of harm to either you or the baby, or probably both of you, is so high that I think it's a valid thing to do. If I would offer termination, then my counselling about pregnancy is different, because I'm so worried about the risk that I think it's better to end the pregnancy than to continue it.
But I guess, when you're having those pre-pregnancy counseling, they're often asking for your opinion, right? And so aside from just information, you often get the question, what will you do if it was your spouse or you?
Yeah,
kind of discussion. So no, I just beyond, because termination, I think, is maybe something different, but I was talking more about the graft. Like, if you're talking about the graft, because in transplant, that loss of graft is a major loss in many other ways. And so maybe it's slightly different than CKD and going on dialysis, maybe not, maybe from the patient's perspective. So I'm just trying to, because you've seen hundreds of these patients, if you have that discussion, or you merely present the information?
Yeah, so I'm brutally honest. And when I say, at some point in your life, we're going to have to talk about a new kidney or being back on dialysis. And if they've got a lived experience on dialysis, that's really helpful because they know what you're talking about. And I say, and we're going to bring it forward 5 years. So you need to decide whether that 5 years of healthy life is worth it. And that's really strong counselling that has data behind it. That's really helpful. And what we don't measure are all the people who I counsel and they decide not to do it. They disappear into the ether, and we don't see the fact that we've actually, saved money and saved harm from not having high risk pregnancies. But I am brutally honest in my counselling in terms of what it's going to do to a graft, which is why that data is really helpful, because we didn't really know before then. But if you're going to, and I don't always say 1.7, 2.1, 4.9. I tweak it. So for instance, if you're CKD 4 and you've got 4 grams of proteinuria, and that's on your ACE and your SGLT2, and I know it's going to kind of be 6 to 8 times higher in pregnancy, and I'm not going to be able to keep you safe, and you are going to get pulmonary edema, and you are going to get a pericardial effusion, and that baby is never going to grow. I say you're also sacrificing your graft for a pregnancy that I don't think is going to have an outcome, and trying to explain that I think the really hard bit is that lots of people say it's black and white, either I'll miscarry or have a healthy pregnancy. And this whole grey area of a sick, small baby on the neonatal unit is quite hard to communicate. But I will sometimes do more than one counselling session. And I also think it's really important to bring partners in. This is their child as well. And this is a child who may not be normal.
Thank you.
So all of that information helps.
Thank you.
I would just chime in and just, my mentor, Marshall Lindheimer, used to tell me always, never underestimate the will of a woman to have her own child. So there have been instances where I've counseled them, they will go ahead and do what they want.
I mean, that's definitely true. People make, decisions that that don't align with what we would do all the time. And you should be allowed to do that in pregnancy. And
I had another practical question. Sorry, I had another practical question. How often are you doing the glucose tolerance test in pregnancy in patients who are on tacrolimus?
So routinely we do screening between 24 and 28 weeks. But if you're on TAC or if you're on a TAC-PRED combination, then I do an earlier test at 16 weeks.
16 weeks is where you start. Because some centers are doing every trimester.
I mean, it's the placenta drives it. So the placenta drives insulin resistance. You've probably not got enough placenta in the first trimester to cause significant insulin resistance. If you're doing it in the first trimester and you're picking it up, they've got type 2 diabetes.
Yeah. So patients who have hemoglobin A1C between 6 and 6.4, would you do it in every trimester? Or you do it at 16 weeks?
So I use different numbers.
So pre-diabetes, what they call pre-diabetes.
Yeah, so sorry, I'm going to have to tell you the British cutoff. So 48 is how we would diagnose diabetes outside of pregnancy. And if they are pregnant with 42, so I think 42 is 6, 48 is 6.5, I think.
Yeah.
If 6.5 is your cutoff outside of pregnancy, 6 becomes your cutoff in pregnancy. So if they book at 6, I have a high suspicion that they might have type 2 diabetes. And again, regardless of TAC or PRED, I would do an oral glucose tolerance test for them at 16 weeks. I tend to not do it before 13 weeks because if anything's going to make you vomit, the first trimester plus 75 grams of glucose is going to do it.
Thank you.
On the same topic of the glucose tolerance test, you mentioned that diabetes is one of the worst, diabetic nephropathy is associated with the worst fetal and maternal outcomes. Why is that? Is it just because diabetic nephropathy is just such a nasty systemic disease? And is there something we can do or is there something going on to try to reduce that risk?
Yeah, I think diabetic nephropathy is a nasty disease. And I think the problem with diabetic nephropathy is it's kind of like double trouble. You have endothelial dysfunction and metabolic dysfunction. And it's kind of one of the only conditions where you carry both burdens. So I look after a lot of women with diabetes, but actually their endothelium, they're young, so their endothelium is okay. And I look after a lot of people with endothelial disease, CKD, that don't have kind of a metabolic burden. And you just get both. And I think in the same way that we know retinopathy and nephropathy go hand in hand, I think it's exactly the same vessel size in your placenta. So I just find they run into trouble sooner. They're more symptomatic of their nephrosis. They need buckets of EPO, like something about their kidneys just doesn't. And the hyperfiltration in diabetic nephropathy is the worst, the hyperfiltration damage. I think they're just primed for that.
And there's nothing in particular that we can do to reduce that risk. It's, treat pre-eclampsia or CKD as is.
No, I mean, so if they're diabetic, I mean, they've going into pregnancy in better shape allows you your pregnancy response, your abnormal pregnancy response to not carry you too far away from the curve, I think. So I'm really, really strict about that's why I showed you about ACE inhibitors and ARBs going into pregnancy, because I think if you stop them and they conceive with poorly controlled blood pressure and proteinuria to begin with, they're just starting from trouble. There's no data, there's some old kind of retrospective data that says, you do better than expected if your proteinuria is down, nothing really useful. But I'm really strict. And so actually we have no data on SGLT2s, but actually I treat them like ACEs and ARBs because I think there's such a good reason to be on it, and actually starting pregnancy in better shape is probably the most important thing, because that goes back to that placentation in the first trimester being a key thing for pregnancy outcome.
one more practical question. What is your target hemoglobin?
So I just want it in. I want it in the normal range for pregnancy. I don't know whether you're grams per deciliter or grams per liter, but 105 or 10.5.
So when do you start EPO?
So as well, I make sure that iron's sufficient. They'll all need iron. Like the iron requirements of pregnancy are huge. 50% of women outside of CKD need iron, and you're just not going to absorb it. So I have a low threshold for IV iron. There's not much IV iron data in the first trimester, and so the obstetric unit won't give it. The dialysis unit don't care, so I give it there all the time. So I just find my route to get them iron in. But if they're on EPO, I'll increase them when they're pregnant. You know,
if they are not on EPO and their creatinine is 150, when do you start EPO?
So as soon as their hemoglobin is falling towards below 1.5, or I will start it, or if it's below there and they're iron sufficient, I'll just give it. And I use so I tend to use the shorter acting ones just because you can get a better. It's quicker to get to steady state, so you can see the response. So my sera I don't use in pregnancy, although I use it outside because I just think you can't wait a month for your response.
Thank you.
Perfect. Thank you. So I think we are almost at the hour. If there are no other questions, we'll stop here. Thank you again, Dr. Wiles, for that wonderful overview of everything to do with CKD in pregnancy. For the viewers in the audience, you will get a email with the survey. Please complete it. We do look at those surveys, and the YouTube recording of this will be put up in a few days once I get to it. And we hope to meet Dr. Wiles in person at one of these conferences.
Amazing. Thank you so much. Thank you for the invite.
Thank you.